Okay, decreased pulmonary blood flow defects. This is Tetralogy of Fallot and Tricuspid Atresia. We're getting into the more serious defects here. There we go. Tetralogy of Fallot is 4 defects: a VSD, pulmonary stenosis, overriding aorta, and right ventricular hypertrophy. So you start out, you have this VSD here, and you've got hypertrophy going up into our pulmonary artery here. So it's difficult for blood to go up here from the right side of the heart. It's trying to go through a straw, so it crosses over and goes up the garden hose instead. So we're sending deoxygenated blood out to the body. Because it's hard to pump up here, we get this hypertrophy of the right side of the heart, the right ventricle, and we end up with the aortic arch overriding the septum instead of being over here over the left ventricle like it should be. So we do get right to left shunting. They're going to start with a shunt, a Blalock-Taussig shunt, which is just kind of to get more oxygenated blood out to the body, help this child grow, and then do a complete surgical repair a little later, somewhere during the first year of life. They're really waiting till the baby's big enough. And I have pictures of the different shunts later, so I'll show you that later. Prognosis, less than 3%. Tricuspid Atresia, this is a pretty bad heart. Our blood returns into the right atria here from the body. Atresia means it doesn't exist, it didn't develop. There is no valve, there is no connection between the right atria and the right ventricle. So blood has to come in, cross over. It's going to keep that foramen ovale open and big, so it can cross over to the left atria, down to the left ventricle, and now this is going to send, this is very low pressure because there's nothing coming in here, right? So it's going to send blood up both the aorta and the pulmonary artery here. Palliatively, they'll do some shunting, build a shunt. They may, depending how much blood is going up into the lungs, they may need to do a pulmonary band, and they may need to do a bidirectional Glenn shunt, and I'll show you that. That's not a very efficient heart when you're talking about these sort of repairs. They're going to end up with a modified Fontan. Again, this does not restore normal hemodynamics. This is never going to turn into a good heart. It's never going to really work the way a normal heart does. Prognosis, mortality rate is less than 5%, but again, this child's not going to have normal quality of life. Here's some of our shunts. That bidirectional Glenn shunt, we take the blood returning from the upper body and the head, and we just skip the heart and send it to the pulmonary arteries here to go out to the lungs. So it's not being pumped at all. It's just passively flowing down from the head and out to the lungs. We can take that inferior vena cava and use the right atria to pump that blood out to the lungs. So again, not a very effective pump. We've closed this off because this really isn't working right. And they can make baffles, actually intra atrial, it can be outside the heart, extra cardiac, but somehow this one's passive and this one's using the atria for the pump. Oh, I thought I had more shunts. They must come later. So mixed deficits here. This is where oxygenated and deoxygenated blood mix together. Transposition of the great vessels, total anomalous pulmonary venous return, and hypoplastic heart syndrome, which can be right or left-sided. Transposition of the great arteries, or the great vessels. This is a very severe defect. Basically, your right side of the heart, the blood returns to the right atria, down to the right ventricle, goes out the aorta to the body, returns to the right atria, the right ventricle, goes up the aorta and out to the body. Are you seeing a problem? I hope you are. Our blood returns from the lungs into the left atria, into the left ventricle, up to the pulmonary arteries, to the lungs, back into the left atria, left ventricle. We basically have two different circuits and they don't mix. So we're not sending any oxygenated blood out to the body. Initially after birth, while that ductus arteriosus right here is still open, the baby will be okay while the blood is, there's some oxygenated blood getting to the body through there, and as that starts to close, this baby will do badly. So unless there's an ASD or a VSD present, there is no mixing of blood. We'll put the baby on prostaglandin to keep that ductus open as long as possible. We may need to do a balloon septostomy to open up between the atria here to allow some mixing. We've got to do something to allow mixing. The surgical treatment, there's really two different ways to do this. One is to take off those vessels that are coming out of the wrong sides and switch them. So now we have more of a figure 8 like we should, instead of two separate circles. The problem with that is not a well, it is a permanent, but you're going to have problems with that. Whenever you take something off and reanastomose it together, you're going to get some scar tissue, and scar tissue doesn't stretch and grow the way normal healthy tissue does. So this child's still going to need dilating where those connections were in the future. We're going to get some problems of stenosis as the child grows, and those sites where the vessels were switched don't. The other possible way to repair it is to use baffles and kind of crisscross the blood. So we're going to take a baffle. You can see here it says arterial switch, or this Rastelli, where we baffle to take the left ventricular blood through a VSD into that aorta that's coming off the right side of the heart, and then we let the right side of the heart go the other way and cross over and go through the pulmonary arteries. So we're basically crisscrossing, making a big VSD and crisscrossing the blood down there so that we leave the vessels. And you know, this really depends on the physician, which one he or she is better at doing. Okay. Total anomalous pulmonary venous return. This is another really bad defect. You should have 4 veins that bring the blood back from the lungs into the left atria. In total anomalous pulmonary venous return, that means those 4 pulmonary veins go to the wrong places. And depending how wrong the places they go to are, is how severe this is. Most of the time it's pretty bad, and you know, these kids don't do great. So we've got a failure of the veins to return to the left atrium. The pulmonary veins can connect to a vein like the superior vena cava. They can go to the right atrium, so we're taking blood from the right side and putting it back into the right side, which is going to increase your blood pressure in your right atria because we're adding too much in there. And then that's going to make shunting over to the left through an ASD, so we're now taking that deoxygenated blood and moving it over to the left. Again, they can go anywhere, and the worse the attachment spots, the worse this is. The surgical treatment, the common pulmonary vein is anastomosed, so disconnected and reconnected to the left atrium. So we kind of find all those veins and take the the biggest one at the end where they should be connecting, and put that into the left atrium so we get some blood going the way it should. We're going to, once we have that established, then we can close that ASD and pinch off or ligate or cauterize or somehow clamp off, make them not work, the venous returns that are going to crazy places. Mortality rate is about 10%. And again, it just depends on how badly these return. But remember that reanastomosing, when you connect two things together, scar tissue is not going to grow quite the way normal healthy tissue does, and so we're not going to have a really normal heart ever. This child's going to have some heart condition that's going to last the rest of his life. Truncus Arteriosus, this is, instead of two arteries coming off of the two sides of the heart, we have one. The pulmonary artery and the aorta are just one thing. So the blood mixes and goes together up here. Some of it goes to the lungs and some of it goes around the aortic arch into the body. So it's a single vessel that's going to override both of the ventricles. Surgical treatment, we're going to need to, well, close that VSD and make two arteries. And often they can do a hemograph, so use some of the patient's own tissues to do that. Prognosis, mortality rate is more than 10%, and there are going to be future operations. If we can do a homograph, that's good. We're probably going to need conduits, which are not the patient's own tissues. Hypoplastic left-sided heart syndrome. Really, whether it's right or left, you're talking about a single functioning ventricle. You're talking about one ventricle that doesn't work. Your right ventricle is not made to be as strong as your left, so having only a right ventricle to pump to the lungs and the heart is bad. Having a left ventricle is still bad. One ventricle is just not enough. So whether it's right or left-sided, you have an underdevelopment of the other, an underdevelopment of the left side of the heart and left-sided, and then the right and right-sided. You are going to have an open foramen ovale because blood from both atria are going into this single ventricle that's working. Therapeutic management, we're going to have to put these kids on inotropic medications, and we're going to keep them on prostaglandin, try and keep that PDA open, just to maximize what we can get out to the body. Surgical treatment, Norwood, bidirectional Glenn, Fontan, and probably a transplant. Prognosis, mortality is between 10 and 30%. And here's some pictures of our shunts. Here's our Blalock-Taussig. This is our subclavian artery and our pulmonary artery, and we're connecting the two here together. So your circulation to your body and your circulation to your lungs. And here's the bidirectional Glenn. This is where our blood just passively comes down and flows to the right or the left lung, because it would cross over here and go to our other lung. And here you can see the Blalock-Taussig here. And this is the Fontan, where we've taken, we had Tricuspid Atresia, so let me see. So we're using the right atria here. So we have no connection here between the right atria and the right ventricle. So we're using that right atria to be the pump to the lungs. And then the left side of the heart is the pump to the body, and this we've just cut off and abandoned. And we've connected it here instead. So that is not really adequate pumping to the lungs. They can live on it, but it's not, they're not going to have the sort of stamina that a normal heart would give them.